Today, this subject is already open and extensively discussed. Dr. Avinash Bundiwal has actually simplified by showing the videos and all that. I will just discuss in a very cursory form that there are two blocks which are usually used for chronic pain arising from the lung. So, peripheral nerve blocks with local anesthetic, with or without steroids, make analgesia that lasts longer duration of action of the local anesthetic in some patients, and that works for several weeks and even months. So there may be very less need of any in using neurolytic in this setting because they are actually fraught with little bit of dangers. If you use alcohol, it can produce neuralgia, and that pain can be more disturbing for the patient, burning sensation, as Dr. Shivrana also said. So phenol is little safer, and near the vicinity of any vascular structure, better to use phenol better to use alcohol rather than phenol. So there are pro and con for using this and that over that. Alcohol has got long lasting neurolysis, phenol has got less lasting. How many? If you make a fresh phenol, then it is better rather than having used it after a few months, because then that loses the neurolysis power. So pain may be there may be temporary loss of nociception when you are using these nerve blocks, causing long-lasting changes in the nervous system that generate chronic pain. So local anesthetics with or without steroids also gives few months of pain relief out of duration of the local anesthetic. Nerve blocks in hospice setting can also be used, and that may be used as a bedside service because patients are very difficult to be shifted to the hospital, and because they require a lot of consenting and relatives and so many other things. So, and they should be not be disturbed. So they are already in the coziness of hospice setting. However, the ASF says, IVX says, resuscitation still apply. All the principles of nerve block still apply before that. And of course, many patients would have DNR, do not actively resuscitate orders. So you have to tell that since patient is having severe pain, so I am using this bedside setting nerve block, which will provide him some 15 days or 1 month pain relief. That is good for the patient, and that will save a lot of opioids requirement. So that should be always be discussed with the patient, discussing pros and cons about this, and proper consent should be taken. What is the rationale of using these nerve blocks? The patient with cancer may suffer from pain due to neuralgia and nerve distribution that may not be directly due to tumor, right? They are often distressed from the diagnosis and may have very limited prognosis. Successful nerve blocks may give considerable relief in these patients. Incident pain may also occur due to metastasis and pathological fractures, which are few contraindications where nerve blocks may not be usually indicated. So we should rule out these two indications. And nerve blocks are usually considered in case of pain, which is refractory to conventional palliation of opioids and adjuvants and other non-opioids drugs and other usually employed procedures. So what are the indications? Chest wall pain may be associated with tumors, which are primary or secondary of the lung, or maybe post-surgical pain, or may arise spontaneously also. Mesothelioma is the best example of chest pain in this setting. On examination, patient has got tender rib or tender ribs, so that should be understood, and that gives you the site of your procedure later on. Intercostal nerve often provides several weeks of pain control in such a patient. Intercostal nerve block should be performed at the site of maximum rib tenderness, right? So these are the various nerve blocks in this territory in the chest wall. So paraspinal nerve blocks, paraspinal blocks, lateral blocks, parasternal blocks. So all this is full list of which are the nerve blocks. So generally, we in chronic pain setting usually mostly use intercostal block, and sometimes we use paravertebral blocks also. If the sympathetic element is there, visceral element is also there, big tumor of the entire chest, involving the chest wall also. There you can block both the things, visceral and somatic and sympathetic. Everything is blocked by one parasympathetic blocks that can be given at the multiple level, or sometimes wherever the most significant is pain, you can give at one level, two level, or sometimes four levels you can. So more levels you use, more success is that, more successful chances. And of course, one doctor has discussed here the volumes and all that. Regarding the, somebody has said 5 to 10 ml of alcohol in this setting. So I have never used alcohol in this setting because it is fraught with dangers, of course. But if somebody is experienced, nothing is contraindicated in the hands of expert. Nothing is impossible. But of course, risk and benefit should be properly delineated and discussed and properly documented. So anatomy of nerve, intercostal nerve has been little bit of discussed, but these intercostal nerves enter the intercostal space across the anterior aspect of corresponding superior costotransverse ligament to lie below the intercostal vessels, first between the posterior intercostal membrane and the pleura, and then rib angles between the internal intercostal and innermost intercostal muscles. Near the margin of sternum, each nerve passes in front of the intercostal internal thoracic vessels, sternocostallis muscle, pierces internal intercostal muscle, anterior intercostal membrane, overlying pectoralis major to become an anterior quotation of the thorax. So there are internal muscles, there are external muscles, and they are in between also. So external intercostal muscles, intercostalis internus muscle. So there are three sets of muscles and parietal pleura below that. So when you give the intercostal muscle block here in the posterior axillary line, then mostly you block all these nerve supplies. You can see here that intercostal muscle is coming, nerve is coming out. So it gives the muscular branches, it gives lateral quotation branches, it gives a few fugues go to the parietal pleura and the anterior cutaneous nerves. So if you give the nerve block here in this setting, then it will block all. If you come little lateral, then few nerves or few figs and few branches are spared. Then you will not have any anterior analgesia. What is the technique of intercostal nerve block? The patient is in prone position. Usually in the sitting, patient may have vasovagal block. So sometimes it is better that patient should be in prone position. And by index finger displace the skin over the rib in the posterior axillary line. Needle should be inserted perpendicular to the skin. Generally, hypodermic needle of 1.5 inch in a thin patient where you can feel the ribs, it is sufficient enough. Okay, but at each level you should have a fresh needle. You should take a fresh needle. Like if the patient is a little thick and the back muscles are too bulky, then you need a spinal needle. Generally 23 gauge needles are enough for using this technique. And needle is walked off the lower ridge of the rib until the bony contact is lost, and the needle is then advanced 3 to 5 millimeter deeper. Sometimes artery is punctured, sometimes vein is punctured because it is a vein artery nerve. So you don't worry, that means you are absolutely in the neurovascular bundle and you are near to the target. So no need, there should not be free egress of the blood in your syringe when you are injecting. So aspirate, you can displace the needle few millimeter, and then again you can reinsert. So there is no direct intravenous any intravascular injection. Otherwise, this is a very highly vascular space. So your total volume of the local anesthetic should also be less, and it should not even few ml of local anesthetic can produce the patient unconscious, and the patient may just lose the consciousness, and patient may develop hypotension, and sometimes even neurological symptoms may come. So everything should be ready. All resuscitation facility, oxygen, everything should be ready. So here the chances of intravascular injection may be also a potential for complications. So this is how the vein artery nerve is. That is the usual teaching. right from our MBBS days. But now this has been debated that it is always not, that this is in one, is not always vein artery nerve is always not there. This is found in various now neuroanatomical studies that this setting is found in only 67% patient. Sometimes nerve is above, sometimes artery is above, sometimes vein is above, right? So you have to hit the rib and then walk over the rib and go down, and then you are in the vicinity of this vascular bundle, neurovascular bundle, where you have to inject 5 ml of the drug. 0.25% of BPBK is enough. Here also in the lateral picture, you can see hit the rib, go below it. Very simple. And what are the complications of intercostal nerve block? Vascularity, of course. So blood levels of local anesthetic can be higher for multiple level intercostal block, and patient may develop tremors or some complication. Peak blood levels may be delayed for, so patient may collapse even after 20 minutes also. So all these patients should be monitored properly, and the anesthetist should not go away after giving the nerve block to see other patients in the OPD. Patient should be closely monitored after completion of a nerve block for at least that interval. Hemorrhage can be a possibility, as I have told you. And if you are going too deep, then of course pneumothorax. Yeah. So always use some ultrasound guidance or some fluoroscopy guidance. So some guidance is required for giving these nerve blocks. So what are the indications for paravertebral block? Already this has been discussed here by the previous speaker, Dr. Bundiwal. But these are the usual indications for which the paravertebral nerve block is given. And even rib fractures, flail chairs, herpes zoster, they are also. Relative contraindications are usually for all whatever nerve blocks. So this is same for all patients. So anatomy has also been discussed. So you have to hit the transverse process and just go below it and reach into the space after piercing the costotransverse ligament. And there you have to deliver. So you will have loss of resistance. So you use too high needle. And when you have loss of resistance, that means you have reached to the space where pleura is just ahead. So you should not go too much in. Wherever, as soon as you have the loss of resistance to in the toe high, your needle in the syringe, loss of resistance syringe, you understand that I have reached in the paravertebral block. So this is superior costotransverse ligament. So that is most important landmark that you have reached. You have reached the posterior border of that. So this is how in the cadaver picture you can see here. And so position is of course prone position and sitting, or it could be sitting position. So in sitting, chances of bursovagal can be 25%. Lateral knee chest position could be good, and you have to mark the dermatomal level, mark upper border of the spinous process in the midline, mark ipsilateral side 3 centimeter from the midline. This corresponds to transverse process of the vertebra below. Aseptic techniques and epidural to high needle set is used. So this is how it is. So you mark 3 centimeter from the spine. You have to mark the spines first and then go 10 centimeters. So you have to use this. So upper border of the spinous process, go 3 centimeter lateral, and you have hit the transverse process. Then you have to come out and go below it, right? And pierce the costotransverse ligament. Then you are there. Loss of resistance into the LOR syringe. You can see LOR syringe here. And this is how you are hitting the transverse process, and then you are going below it, overcoming it, right? So you are in the vicinity of the paravertebral space. And this is how the spread of the drug, you can see, and contrast can be seen into the paravertebral space. This is how the paravertebral space, your injected would spread around that area. So preemptive dose of optimal effect with a lipoBBK 0.25% 3 ml per dermatomal level. Then continuing analgesia could be further bolus of BBBK 0.25% 10 ml. Hourly, if you are using continuous block, infusion can be used. And there are no opioid receptors, so there is no justification for using any morphine and fentanyl into this space. And single shot versus catheter versus confusion is you have to choose the case and select what is required in this patient. So what agent bupivacaine is standard? Bupivacaine offers advantage because 75% potency of bupivacaine, superior safety profile, agent of choice for high doses in the ward. Ropivacaine, less potent, only 60% potency of bupivacaine. You can use adjuncts, but it is also debatable. Complications of Peripheral, technical failure in 10%, more challenging than the intercostal block, which is very simple, unable to cite, continuously analgesia failure, pneumothorax, hemothorax, inotran epidural, and Horner syndrome. High speed, you can cause ipsilateral hand weakness also in 0.5% cases. So this is how ultrasound guided techniques are used in plane and out of plane. And this is the space between the intercostal costotransverse intercostal muscle and the pleura and the transverse muscle. So this is the space here, which is to be flooded with your local anesthetic to successfully block. It's a continuous space from up and down. Okay, so sometimes some people who are expert with a single needle technique, they have described breast surgery also can be done by this technique, right? And it can be, sometimes you can get away with this also. By single technique, if you give 20 ml, the entire ipsilateral chest would have excellent analgesia. So this is ultrasound image of the paravertebral space lateral to the transverse process. And these are the papers for that, where to catheters go and all that. So catheters can also go, or this was the space of head and neck tumor, you can see here. And then that has the recurrence into the chest, and he was having severe pain. And this was very old patient, like in 2007, I have given this block, and then it was multiple times I have given this paravertebral block, and that was very nicely gone into the pain relief for about 6 months. So carry home message from this presentation is that chest wall nerve blocks applied where opioids and other palliative options are failing and not giving even 50% pain relief. All blocks should be performed with informed consent after a thorough discussion with the risk and benefit. Neurolytics are usually not used due to neuritis pain, which can be worse than the original pain actually. But of course, in the hands of expert, nothing is contraindicated. There is more scope for suffering OPD pain patients who are otherwise fit but suffering from so much pain, and mesothelioma is one of the examples. So with this, I thank Dr. Chaguthota for giving this opportunity and the organizers of lung masterclass. Thank you very much.
Thank you, sir.
Thank you.
So it was well covered. The peripheral nerve injection, especially focusing on the intercostal nerves and the paravertebrals. So any questions from the house? All right, sir. Thank you very much.
Thank you very much.
So with this talk, then we will move ahead with our talk where Dr. Shiv Pratap Singh Rana will be speaking about the intrathecal